Well, both of those talks are going to be a hard act to follow. Great discussions about upfront treatment, but I think regardless of what we choose for transplant and non-transplant patients, many of them relapse. And so we need to know something about the therapy for patients beyond first-line therapy, and that's my topic for today's talk. These are my disclosures, and I'm going to also start with a case. A 63-year-old woman with lambda light chain AL amyloidosis and a past medical history of hypertension and hypothyroidism presents with Mayo cardiac stage 3 disease and Pavia-Heidelberg renal stage 2 disease, and the renal disease was on the basis of proteinuria. Initial therapy for this patient was Cybord-D for 6 cycles, and the patient achieved a complete hematologic response. There was an improvement in cardiac biomarkers, but no renal response. So the patient had persisting proteinuria. And 3 years later, which is a long time for Cybord-D, as we heard, the lambda light chains began to rise and proteinuria began worsening. Daratumumab was started as second-line therapy, but after the first 8 weeks of therapy, the patient had achieved less than a partial hematologic response. What should we do now? So here are our choices. We can continue daratumumab to see if the response does actually improve over time, switch to IMiD-based therapy, initiate other chemotherapy, evaluate eligibility for high-dose chemotherapy and stem cell transplant now as second-line therapy, or consider a clinical trial. Please vote. Okay. D seems to be the runaway favorite, which surprises me, and we'll talk about the data for all of these options as we go forward. I actually had as my answer any of them, although I thought that A was probably the weakest choice because the chances of a response continuing to improve after the first 8 weeks is probably in the neighborhood of 15 to 25%. And so there are other options which would have a higher chance of inducing a response, and any of these other things I thought could be considered, and we'll go through them. Before we do that, though, let's talk about the considerations that we make when we're thinking about second-line therapy or just therapy for relapsed amyloidosis in general. First, obviously, we're assessing whether resumption of therapy is actually indicated based on rising light chains or deteriorating organ function. We think about how the amyloidosis responded to an original therapy, and also, did the patient progress on last therapy, or did the patient progress sometime after that therapy, suggesting that they may not be completely refractory to that agent. How did the patient tolerate initial therapy? Were there side effects or problems with a specific regimen? And is the patient's health status now, as we consider therapy for relapse disease, different than their health status was originally? Could be worse due to progressing symptoms or persisting side effects. Could be better because of the response that we saw with initial therapy. And did the candidacy for any of the therapy options that we listed actually change now compared to when they were first diagnosed? And then are there any coexisting medical problems which might affect the choice, specifically by making certain side effects more problematic or more likely? The question I always ask, of course, is there a clinical trial available? And I would emphasize to everybody that they should be thinking about that if we want to move the field forward. So in terms of the timing of initiating therapy, this is highly variable. Even at the Mayo Clinic, an internationally renowned center of excellence, when they looked at their own internal data about the reason for initiating second-line therapy after relapse from first line, the reason varied. In some cases, about a third of patients, it was a rise in the light chains. In another third of patients, it was a rise in the light chains with deteriorating organ function. In another subset of patients, it was just deteriorating organ function. And in some patients, it was actually much less defined than that. And this is at one of the best amyloidosis centers in the world, which I think underscores how confusing it can be for physicians who see far less numbers of patients. I think there are some situations where it's actually an easy call. When a patient has a rising involved free light chain and a widening difference between the free light chains with deteriorating organ function, that's a no-brainer. Therapy should absolutely be reinitiated at that time point. It's a little bit harder with an asymptomatic rise in the light chains, but I think most people are moving towards reinitiating therapy as light chains start to rise, particularly if they're rising quickly. And then the hardest call, I think, is organ deterioration without a rise in the free light chain, the involved free light chain. It's important to remember that there are some patients who may have deteriorating organ function not as a result of continued amyloid deposition, but as a result of disease processes set in motion. The one I think that we commonly face is the patient with persisting proteinuria and renal injury from the proteinuria rather than ongoing light chain deposition. But that said, in my own practice, I'm most inclined to treat these patients if the residual stable light chain is actually still elevated and not in the normal range. That, to me, is a subset that I'm inclined to treat with declining organ function. So let's start going over this case and the choices for this question. First, the daratumumab, before we ask the question, that was a good choice. The data on daratumumab in relapsed amyloidosis is actually outstanding. There have been several retrospective case series now published. One of the earliest ones was from Dr. Kaufman and colleagues at Stanford. This was 25 patients who had had a median of 3 prior lines of therapy, and the overall response rate was 76%, with more than half of patients achieving a very good partial response, which means a marked decrease in the involved free light chain and a difference between the involved and uninvolved free light chain of 4 milligrams per deciliter or less. At this meeting, there's an interesting abstract by Dr. Milani, who's sitting right over there. 72 patients with amyloidosis in Italy who have more than 10% plasma cells in their bone marrow, making daratumumab available to them. These were all relapsed patients, and 65% of the patients got daratumumab alone, and the other third of the patients got daratumumab combinations like we use in multiple myeloma, pretty much a split between DVD and DRD. And in this patient group, they had also had a median of 2 prior lines of therapy. And interestingly, the response rates, whether they got monotherapy or combination therapy, was above 80%. And there was actually no statistical difference for the combinations compared to the monotherapy group, although the numbers were a bit small to really prove whether there was any significance or not. There have been case reports of daratumumab combinations published. This is an example of one, a patient who had a light chain plateau with clinical worsening after 5 cycles of Cybor-D, and they were switched to daratumumab, pomalidomide, and dexamethasone, had an excellent hematologic response, and ultimately was able to go on to autologous stem cell transplant. And I think we're going to be seeing more and more use or interest in daratumumab-containing combinations, but based on some emerging data in a randomized study that we've already heard some details about from Dr. Comenzo at past meetings, daratumumab may very well be used up front soon. This is a study comparing Cybor-D with or without subcutaneous daratumumab, followed by daratumumab maintenance. That's a 370 patient randomized trial, but we did have a safety run-in for this combination where all the patients got treated with the study arm, and the response rates of 92% with 3/4 of the patients achieving a VGPR are in excess of what we expect for Cybor-D, even though this is basically the equivalent of a phase 2, and we shouldn't get overly excited. This has definitely prompted enthusiasm for the idea of adding daratumumab to chemotherapy and amyloidosis, as it has in multiple myeloma. And if this actually comes to fruition and patients are getting daratumumab up front, we're going to need to do a lot of work to find out about how to use it later or even if we can use it later in other combinations. Final thoughts on anti-CD38 therapy. As I mentioned, sub-Q DARA is going to become available. That will be very helpful for our patients, both in terms of the infusion time, but also the fluid load for amyloidosis patients. Isatuximab with dexamethasone is being studied in a Southwest Oncology Group trial right now, and there's also an ongoing trial at MD Anderson of daratumumab, ixazomib, and dexamethasone in relapsed patients. So choice B in our question was IMiD-based therapy. There's been tons and tons of phase 1-2 level data using IMiDs. The initial work was with lenalidomide starting back in 2007, and in the earliest studies at Boston and Mayo, the thing we really found out is that lenalidomide can't easily be used at a full myeloma dose in amyloidosis patients, and the starting dose for patients, particularly frail patients, probably ought to be 10 or 15 milligrams, and it's unusual to treat patients with higher doses of lenalidomide. This actually led to a number of patients coming off study from the Mayo phase 2, and that's probably what explains the lower overall response rate in that particular study. I think what we see in the other studies here is that the response rate is in the 50 to 65% range with lenalidomide, and in the more recent British and Greek series, we see that the response rates in patients who previously had bortezomib, so relevant to our patient, we expect response rates also between 50 and 60%. So definitely a potentially useful agent in this group. There's also data on lenalidomide, Cytoxan, and dexamethasone that's been published by several centers. I'm not going to show you that data. That's also feasible to give. And then we have more recent data on pomalidomide, also numerous phase 1 and 2 type studies. And the later ones, almost all of the patients had prior bortezomib, and we're seeing response rates again in the 50 to 70% range. So similar to what we saw with lenalidomide and dexamethasone, but I think more data relevant to the patients we're currently treating based on prior therapy. And the median time to progression with IMiD-based therapy is generally in the 1 to 1.5 year range in these studies. So what about other chemotherapy options? I wouldn't be giving a complete talk on treatment of relapsed disease if I didn't remind all of us that we actually have pretty long-term data on just bortezomib monotherapy or bortezomib with dexamethasone. Very active for patients who previously were treated with transplant, for instance, and then relapsed, and could be a consideration for a patient with relapsing disease in that setting. At this meeting, I think one of the more exciting abstracts that we're going to hear about from Dr. Dispenzieri is the tourmaline AL1 abstract, which is a randomized study of ixazomib, dexamethasone versus dealer's choice in relapsed AL amyloidosis, 1 to 2 prior lines of therapy. And dealer's choice could consist of Lendex, Thaldex, Cydex, or Meldex. So all of those are reasonable regimens. So this is real life control arm. The results of the trial somewhat disappointing in that the response rates were not different between the two arms, but all of the time to events, most of them actually favored the ixazomib and dexamethasone. We see here a graph showing that time to vital organ deterioration or death did favor ixazomib, and this was one of the 2 primary endpoints for the study, and other endpoints such as progression-free survival and time to next therapy also tended to run in this direction, favoring ixazomib. We have data on another proteasome inhibitor as well, carfilzomib and dexamethasone. This is a phase 1-2 study from a few years ago, reported by Dr. Cohen. Almost all of the patients had prior bortezomib, and although there was a pretty robust response rate, there was also a pretty significant rate of grade 3-4 cardiopulmonary adverse events, including 3 patients who had hypertension. And I was thinking about our patient when I was looking at this data, that carfilzomib dex might not be the best therapy for this particular patient. But there is ongoing work with carfilzomib, and I'll show you a case report in a little bit of a patient who got a carfilzomib regimen with some benefit. There's been a phase 2 study of bendamustine and dexamethasone presented by Dr. Lynch. This is a 31-patient study, and the starting dose was 100 milligrams per meter squared for 2 days in a row out of every 28. Response rate was 50%. Progression-free survival was about 9 months. There were occasional organ responses. The toxicity was fairly typical for alkylator type therapy, and about a third of the patients on this study did ultimately require dose reduction. I think one of the most promising things about this particular regimen is simply the convenience of a therapy that you get for 2 days in a row once a month and then can go home and forget about in between. Let's talk about the next option, which was evaluation for high-dose chemotherapy and autologous stem cell transplant in relapsed disease. So I'm showing you data here from the UK National Amyloidosis Center, which compared outcomes in patients who got transplant as part of upfront therapy versus patients who got transplant as part of second-line therapy. And I don't know why I bothered to tell you which line was which, because the lines are superimposed on each other, and so it doesn't really matter which line is which, right? They basically did identical. And what they emphasized in this report was that they probably did identically because the patients were selected with the same stringent criteria, whether the transplant was being done as first-line therapy or second-line therapy. Now, I was surprised that in our group, transplant was the runaway next choice, because I mentioned that the patient was a cardiac stage 3 patient, and in this series only 5% of the patients were cardiac stage 3, so this data doesn't really represent our patients. But Dr. Hua and colleagues at Mayo Clinic did publish data showing that the Mayo cardiac staging system has prognostic significance when it's used to restage second-line patients like it did in first-line patients, and that actually that scoring is independent of what the patient scored at with first-line therapy. So it brings me back to that point that I made, that we should reevaluate the patient and see if perhaps they're a candidate now, even though they weren't before. I mentioned our patient did have some cardiac improvements, and if her cardiac status did slip into transplantability, then I guess the 60-something% of you that voted for that could be right. That could be a consideration. There is I'm going to mention in passing, there's an abstract from Cornell with 24 patients that sort of asked a similar question to this, and their conclusions were exactly identical to the British results, and that'll be viewable as a poster at this meeting. But I think what we have to ask ourselves is not just, could a patient be a candidate, but, and is the transplant likely to be as effective as upfront transplant? I think the other important question is, how likely is the transplant to be effective compared to other therapies that are available at that time for that patient? And this data, also from Mayo Clinic, suggests that transplant really is just one of several options that has pretty similar overall outcomes. And this analysis actually is in the pre-DARA era, right? And so if you included DARA with some of these other agents, or included a curve of just DARA-treated patients, you might actually have something that pulls up away from transplant in this. So it's important to remember that we shouldn't feel pressured to consider transplant or stretch the eligibility criteria for transplant just to use it when other very effective agents are available as part of second-line therapy. I just want to show one slide, for informational purposes. If our patient had actually had transplant as part of her first-line therapy, could transplant be a consideration for a second-line therapy? And actually, both Boston and Mayo have published a small amount of data on this, between them just about 20 patients. And I think what this shows us is that, yes, you can collect stem cells in some of these patients. Yes, you can get responses in about 50 or 60% of patients. But the Boston data at least suggested that the duration of response may not be as durable as with frontline therapy. So I want to close by talking about some emerging agents. And as you can see, even with the established agents, it's all phase 1-2 data, except for this recent Exasumab study. And so when we're talking about emerging agents, we're talking about things that have been reported as case reports. Elotuzumab is one example of this. This is an anti-SLAMF7 antibody that we are using routinely in multiple myeloma in combination with IMiDs. It was approved in combination with lenalidomide and pomalidomide because of the improved progression-free survival when you add it to those agents. There's a case report of a 51-year-old woman with kappa light chain AL amyloidosis with renal involvement who had, over a period of 10 years, and the purpose for the purposes of time, several different therapies, including KRD. I told you carfilzomib can sometimes be used. In 2015, this patient got 8 cycles of KRD as fifth-line therapy, had a partial response but kept having deterioration of renal function with increasing proteinuria, and KRD was swapped out for ELO-RD, and the patient promptly had a hematologic complete response, and at the time of this publication had been on therapy for 28 cycles. And when we look at the proteinuria, we see that proteinuria was actually at its lowest point at any time along the course of this patient's illness during the time that she was getting ELO-RD, suggesting this was a very effective regimen for her. There is an ongoing multi-center phase 2 study of ELO-RD ongoing right now, this is the clinicaltrials.gov number, so you can find out more information about it. We saw this slide already. Actually, this is one case report of a patient who got venetoclax and Velcade in the setting of a T1114 translocation. We know that the myeloma patients with this translocation are particularly responsive to venetoclax-based therapy, probably because of dysregulated BCL2 expression or changes in the BCL2-MCL1 ratio. This is a BCL2 inhibitor. I'm going to skip over this slide and go to a separate case report of a person who was treated with the combination of venetoclax and daratumumab for relapse disease. And what we can see here at the bottom, you see the varying lines of therapy. And when daratumumab was started by itself, we saw an improvement in light chains, but it plateaued at a level that was still somewhat elevated, with persisting proteinuria and elevated cardiac biomarkers. And then venetoclax was added, which pushed the response deeper, and the patient had both a renal and cardiac response and ultimately achieved MRD negativity in this particular case. So both of these case reports, I think, argue in favor of studying venetoclax in AL amyloidosis as it's being studied in multiple myeloma, and Ray Comenzo has had a trial open at Tufts looking at venetoclax and dexamethasone, which I think is on a partial clinical hold right now and is not accruing patients, but hopefully we will be able to get these kinds of protocols back on track for this agent. In closing, summary and final thoughts. There's lots of variability in the timing and rationale for starting treatment for relapsed AL amyloidosis, and it should be considered on a patient-by-patient basis. Effective therapy, I didn't have a chance to really talk about this data, but a cost and resource utilization analysis that was done by a group of researchers, which included Dr. Sanchorwala, suggests that effective therapy for relapsed AL amyloidosis can actually reduce healthcare costs. In that analysis, the monthly cost of taking care of a patient with relapsed AL amyloidosis was $15,000, and 2/3 of that was managing the medical complications of the patients because of their amyloid-related symptoms, and it was not medication costs. And particularly because right now in amyloidosis we don't use maintenance therapy, right? We don't use maintenance therapy. The place where we can really make an impact is eliminating those medical complications by getting better disease control. Now, maintenance strategies, trials like some of the ones we've heard about, or ongoing use of antibody therapy over time might undermine this analysis a little bit, because the drug costs will definitely go up if we start using maintenance strategies in amyloidosis. Daratumumab-based therapy alone and possibly in combos is very effective, and we're going to probably be using it up front soon, and we're going to need to figure out how to use it in the relapse setting after that. Other myeloma drugs have utility, but it's important to recognize that some of them, like carfilzomib, may be more toxic in amyloidosis patients, and same is true of other more commonly used ones like lenalidomide, which can't be used at full dose, or dexamethasone, which is routinely started at a reduced dose in patients at older age or with cardiac involvement or edema. And finally, clinical trials should always, always, always be a consideration if we're going to move this field forward. I'd like to just end in my last 50 seconds by thanking several people. First, Silva Preja, who keeps everything running at Hermanos with our plasma cell team, but also was really responsible for virtually everything that went on with this symposium. And Silva, thank you, Falam Derrit, for all the work that you did on this symposium. Other colleagues who are part of our myeloma team who were also helpful putting this particular day together, and all the people in clinic who help take care of our patients and are so important, particularly for our patients on clinical trials. Finally, the generosity of the McDevitt, Silver, and Ring families who have provided really great support for our program over the years. And then also amyloidosis support groups and the Amyloidosis Foundation, both of whom directly supported this symposium. Those two organizations, plus the Amyloidosis Research Consortium and the Multiple Myeloma Research Consortium, who do so much to advance research in plasma cell dyscrasias. Thank you.